Well, 1 in 3 emergency hospital admissions is of a confused older person, and hospitals are not well set up to dealing with such a complex and vulnerable group, and staff report that they struggle with the difficulties they present. So we tried to establish a specialist unit that would do this properly according to best practice, and then we wanted to evaluate it to see if it made a difference. The first thing we did was we employed some mental health specialist staff, nurses, occupational therapists, psychiatrists, and we integrated them in with the ward team.
We introduced person-centred care to the ward through time-out days and training, and specialist dementia and delirium training as well.
Person-centred care is about enhancing our view of the patient as a person with a history, with values, with likes and dislikes.
We adjusted the environment to make it more appropriate for people with cognitive impairment. So the different bays on the wall were painted different colours. We had better signage and orientation.
We introduced a programme of organised activity to keep patients occupied during the day. This was things like singing, music, quizzes, games, a whole range of activities.
The ethos of the ward was that anything could become an activity. So if patients having a wash in the morning, we're promoting independence, promoting that as an activity of the day.
And then finally, we had tried to have a more proactive and inclusive approach to family carers. We did a randomised controlled trial. We recruited 600 patients who were identified on the acute medical unit as being confused, all over 65, and we randomly allocated them between the unit and standard hospital care. And the standard hospital care was about 70% specialist acute geriatric medical wards and 30% general medical wards. We then recruited people into a follow-up study and followed them up for 90 days.
We also took a subsample of 90 patients and did observations using dementia care mapping. In dementia care mapping, you watch your patient for 6 hours, and every 5 minutes you code the patient's mood and engagement, their activity, and the quality of staff interactions.
And the final thing we did was a family carer satisfaction survey. This was done by telephone about a week after the hospital admission, and across a whole range of different areas of care, family carers were more satisfied with care on the specialist unit.
So we recruited a group of patients who were very old, with a median age of 86. 2/3
had a prior diagnosis of dementia, and 60% had evidence of delirium on admission. They were also quite dependent in terms of physical abilities, and also a lot of psychopathology. About 2/3 had evidence of agitation or hallucinations or delusions or anxiety. Our main outcome was the number of days that people spent at home in the 90 days after randomisation. And this is a composite outcome that takes account of deaths and lengths of stay and readmissions and new care home placements. And we found that people on the specialist unit spent a median of 6 extra days at home, but this was no bigger than could have arisen by chance. Other health status measures were no different as well. We had hoped that providing more appropriate and specialist care would improve the standard of care, but also save resources by shortening hospital length of stay or readmissions, and that didn't happen. There are several reasons why that might have occurred. One is that the patients were simply so frail that it was very difficult to change those sorts of outcomes. So about 25% were dead within 90 days of randomisation. A second possibility is that some of the outcomes were very dependent on community services and family choices, and we had no control over these. And a final possibility is that the comparator, which was mostly specialist geriatric medical wards, was good enough. Although we did look at recorded care in the case notes, and the care on the specialist unit was definitely different in terms of assessments and communication and use of follow-up services.
We saw that patients had a better experience of care, their mood was better and they were more engaged in activities, and we also saw that the quality of staff interactions were better.
We've got to think very carefully about how we define quality of care for a very frail group of people approaching the end of their lives. We had anticipated that with good care we would be able to adopt a sort of rehabilitation mindset and get people home and functioning again, when actually this is more of a palliative care intervention, and I think that patient experience and carer satisfaction are probably more important as outcomes in that setting.